Well, good afternoon, everyone. I see that it's 12:01. We might still have a few folks joining, but just to be very mindful of time, we all have, lots of things going on, and we're so incredibly grateful that you're here with us today. So, welcome to today's webinar, Stronger Together Against HIV, Building Trust in HIV Care, a provider peer panel. This webinar will bring together multidisciplinary perspectives to discuss strategies for strengthening trust between providers and patients living with HIV, exploring practical approaches to improve patient engagement, enhance communication, and also while addressing stigma and navigating social and structural barriers to care. My name is Chloe Delgado Loving. I use she, her, aya pronouns, and I am a bilingual public health leader with a master's in public health. I'm also a certified health education specialist. I have focused my career on health equity, empowering underserved populations at the local, state, and federal levels. Most recently, I was at the Department of Health and Human Services, supporting the Presidential Advisory Council on HIV and AIDS as well. And storytelling and advocacy have been so central to my journey, so you can only imagine how excited I am to be here today. And just before we get started with this wonderful conversation, a few housekeeping items. This webinar is being recorded and will be shared via NHMA's YouTube channel and website. We understand that microphones are muted for the session, so please use the Q&A function to submit your questions throughout the conversation, and we'll have time for a live Q&A and also just hear from our amazing panelists. For those of you who may be new to the organization of the National Hispanic Medical Association, we are a nonprofit organization that represents over 50,000 licensed Hispanic physicians in the United States. Our mission is to empower Hispanic professionals as well as other underrepresented healthcare professionals to improve the health of the communities that we represent. We advance this mission through leadership development, health policy, advocacy, education, and also strategic partnerships with, important folks such as federal agencies, academic institutions, and of course, the community-based organizations doing the boots on the ground work across the country. And today we are honored to be joined by two incredible speakers who bring a wealth of knowledge and experience as health providers serving people living with and also at risk of HIV. So you will hear from Dr. Claudia Martorell, Director and Principal Investigator at the Research Institute in Springfield, Massachusetts, and Dylan Brooks, a registered clinical social work intern and mental health therapist at the Compass LGBTQ+ Community Center. Together, they will share insights on how healthcare professionals can collaborate in HIV prevention, especially within Spanish-speaking communities. So we'll begin today's discussion by hearing from each of our speakers, each of our panelists, about a little bit of what they do and what their daily work entails. I will begin with Dr. Martorell.
Hi, good afternoon. I am Dr. Claudia Martorell. I am an infectious disease specialist. I work currently in Springfield, Massachusetts. I have been in practice for over 20 years. I was born and raised in Puerto Rico. Besides seeing patients clinically, I also direct the Research Institute, which is clinical research. And many of the most of the medicines that are approved now we have been a research site for those medications. And I think that has, increased access to care to many people that have insurance and do not have insurance. I hold a master's in public health, so prevention, HIV treatment and prevention is very important in the practice setting that I work at. And I also have training in health policy and minority health policy. So we emphasize on seeing everyone in the practice. But of course, me being from Puerto Rico, there is a large Spanish-speaking population in the region where I work, in particular people from Puerto Rico, so that attracts a lot of these clients or patients to the practice. I love what I do, and hopefully the insights that we'll share will be helpful for some of you or many of you. Thank you.
You already know they will be. We're so lucky to have you today. You know, your communities and your patients are so lucky. And so thank you so much, Dr. Martorell, for sharing with us. And Dylan, we want to give you some time to introduce yourself and tell us a little bit about your amazing work.
Thank you so much. Good morning, good afternoon, wherever you are in the world. My name is Dylan Brooks. My pronouns are he, him, and his. And I currently work for Compass LGBTQ plus Community Center here in Palm Beach County, Florida. I've been with Compass for about 11 years now, but in the field of HIV prevention and education for about 15. I started up in rural Northeast Georgia, where I was born and raised. This little gay boy was raised on a farm, so I kind of know a thing or two. And then adding in like working with migrant farm working families and up in Georgia, as well as when I moved down here, we have a great working relationship with our local migrant farm worker community. It's very interesting, the dynamic here in Palm Beach County, including the state of Florida, as well as the rest of the country, as I'm sure you all know and have dealt with and are currently dealing with day to day. So yeah, I'm looking forward to the conversation and yeah, thank you.
Well, we're very lucky to have you. And, you know, thank you to you both. Not only are you providers, but of course, your work speaks for itself and that you're advocates. And so thank you for what you do to change and save lives every day. It's not light stuff. And so we want to go ahead and transition, excuse me, over to the Q&A panel. And so we want to give our participants some time to ask these amazing providers questions. I'm not seeing any questions come in just quite yet, but feel free to at any point during our discussion pop in those questions. We want this to be a time for you all to, you know, really discuss with these amazing folks, and feel free to, you know, just pop in whenever you'd like. But we'll go ahead and we'll start with Doctora, if that's all right. We would love to ask, how can research institutions better partner with communities to build trust and ensure HIV prevention and care programs are culturally sensitive but also accessible?
Yes, so my site is both clinical and research. So I think that's an advantage, right? Sometimes you have a separation between a research side and there is no connection between the clinical aspect on how to translate research findings into the clinical setting when you see a patient or a client. I think that has been an advantage. But one of the things is adapt to change, be very good with change. There's been a lot of change over the past 20 years that I have been in practice or longer. And to be honest, there's been a lot of change in the past few years. So, adapting what you do and changing and being willing to change it will be important, not only for the setting to survive in terms of providing services or medical services or research services, but also attracting populations that may need those services, especially people that may be disadvantaged and may not have the access, whether it's insurance or whether they may have developed any new issues that may need to be addressed. Because if they don't get addressed, then they don't really take their medicines or they don't go and see the provider. One of the things is incorporating new services. Over time, we have had to incorporate, services for the LGBTQI community, prescribing hormones. I do that. Also, substance use disorder. There's been changes with substance use disorder. So in the same setting, we provide MAT. In the same site, right? You have a research and a clinical site. In the clinical side, you provide those services. Because what I noticed is that if people are not getting treated for substance use, then they are not compliant with their HIV treatments or treatments in general. The Having people from the community that you serve, right? I am from Puerto Rico. I am from this area. The medical assistants, the other providers, they are from the same region, so they know the community, the language, the culture, the barriers, because they go through similar or the same barriers with their own lives. And I think that is important for to develop trust, the aspect of trust. So it's not only research, it's incorporating all of those changes that I think, and getting adapted to those changes that
Mhm.
will then make the site successful in terms of providing quantity and quality of care for those patients. And those are some examples. We have incorporated social media to
Mhm.
address the misinformation.
Yep.
There's a lot of misinformation in healthcare, so we have had to make some adjustments or some changes in that to try to provide, accurate information. And yeah, we have a few other examples.
Yeah. No, that's wonderful. And I think it's really incredible that, even after such an extensive career, you still have that humility to always learn and to always pivot and be adaptable. And so you mentioned this a little bit, but obviously you're a very trusted messenger. And so just a little bit of a follow-up question to that. What structural barriers, do you think are most impactful when looking at trust? And not to put all the weight on providers already do so much, but what can providers on their side realistically do to kind of navigate that, if you wouldn't mind expanding on that just a little bit?
Yeah, so there are many barriers, many. And again, they have changed and evolved over time. You know, One of the most important ones, even though Massachusetts is a state where there is universal healthcare, not everyone has insurance, and that is a structural barrier. Even the access to some services is lacking. There is a shortage of mental health providers, for example, even specialists. I mean, even primary cares, right? It's taking like 6 to 9 months to get a new appointment with a primary care. So those are part of structural barriers. There are many others, like changes with immigration policies, right? That is a big one, especially when you want people to go and get their health services and trust. Because when there is changes in many of those aspects, the issue of trust, or they are sick, but wait, what's going to happen? And then they don't necessarily attend, or we have had to adapt to that too. And then, the issue of telehealth, for example, or telemedicine has been helpful in addressing some of those barriers besides, the COVID issue.
Mhm.
Um, Even research, right? I am an investigator. Not
Mhm.
every patient or person is willing that even for that, because there is the trust, right? Because I know, I start seeing someone at different stages in their life. When
Sure.
I feel like I have known them for a while, that's when I start talking about research. You still hear a lot I'm not a guinea pig, right? Those concepts, because there has been negative experiences with research, especially in the past with many populations, including underserved minority populations. So even that aspect, you have to um, not only have the research protocols that will I try to choose protocols that serve the patient populations that I'm seeing or
Mm.
that address new needs, right? Looking into cure for HIV, for example, or prevention protocols, right? So those, I think that when you know someone, eventually that trust is
Yeah.
there, and they know that that the provider is doing their best to provide the best service, but also to really have that person healthy, and the family, the concept of family, especially in the Latino communities,
Yeah.
very important. Not only caring about the patient, but also the family and what else is going on. It's not only the vital load or the CD4. It's
Mhm.
also, what's going on with your housing situation now. A lot of people are being displaced. Transportation, they used to have a car, now they don't. The prices, changes in pricing, right? And how that impacts care. So uh, when they see that you care about those things and that you
Mhm.
try to do something about those other things and you adapt and change, it's important. um, then that trust gets established, and it's easier to
Mm.
then achieve the goals that may be different for different people. I mean, partnering with, I said that, for example, at our site, we have had to make a lot of adjustments over time. We
Mhm.
cannot do them all. I can start someone on a depression medication as an infectious disease internal medicine doctor, but I am not an expert on that, right? So over time, I can start them, but then I have to partner with a community-based organization, a case manager, someone that can provide them the therapy, the mental health
Mhm.
services. Even for housing and transportation, we have had to partner with some of the community-based organizations, which is great because it's not only you or the provider, it's the community trying to help the community and improve services for the community, and that's very important. And not only that, a case manager, I respect every healthcare provider, but case managers, highest respect, because they have a lot more time than a provider to get to know or see what's going on. And they get a lot of information that is not tattletale. But when that case manager shares that information, it helps me as a provider to then offer some things that I didn't even think about or become aware of some issues that maybe that person was not willing to tell me, or they trusted more the case manager, or they had the time, or the way that the case manager asks is different, right? We providers go more with the clinical questions, but the case managers. So that relationship, in my mind, is the best relationship, and the one that has been one of the most helpful. And there is many others that we can talk about, but those are some. Yeah.
Oh, that's absolutely wonderful. And just the way that you listen to your patients, the way that you meet them where they are. And I know that you're not a specialist in all grounds, and that's where we have amazing providers like Dylan, um, who have those mental health, that background, that experience. And so, Dylan, we want to shoot this question over to you, if that's all right. What can medical providers learn from, trauma informed care? How can we make a client to feel safe enough to engage in treatment or services? And maybe if you could share a moment where you really saw trauma informed care kind of be the star of the show, and in treating the whole patient. So if you could tell us a little bit about that.
Yeah, absolutely. So I think I forgot in my intro that I was previously the director of our HIV prevention education program, and as of October of last year, I have joined our mental health team full time as a registered clinical social work intern. I've already passed my exam. I'm just waiting on the hours, so it's kind of like a little LCSW in parentheses style situation going on here. I say all that to say that Dr. Martorell was on point when it came to like talking about collaboration and having that effective collaboration really at the end of the day. Because like when you think about trauma-informed care, the principle at the very basic is changing the what's wrong with you to what happened to you, to
Mhm.
see what got you from here to here and what kind of issues and changes happen along the way. So if you look at like Maslow's hierarchy, for example, those bottom two layers of physiological needs and safety needs, those, yes, absolutely. Clap it up for Maslow. As much as we love and hate that man sometimes, he really was onto something. Um,
Yes.
but yeah, no, so like, I mean, if you don't even have those physiological needs met, and Dr. Martorell brought this up as well, like, why would you even take your medications? Why would you come to a doctor's appointment if I have $10 and it's in between getting something to eat or paying a copay? Honey, I'm thinking about right here, right now. So when
Mhm.
we start looking at like what is the stuff that's happening in the background for clients, I think it's easier for us to kind of see like what's happening in the foreground and how to work better for the future, really, with when it comes to working with our clients. So from a trauma-informed aspect, like let's bring in the safety concept because safety is that second layer of Maslow. And I have one client who I've been working with who came from they grew up in a domestic violence situation, lower socioeconomic status, so on and so forth. They were queer, couldn't come out. And then when they moved here, they're like, my brain still feels funny. And I'm like, because you lived in that safety, like, I don't have safety mindset for so long that now you're kind of like, oh, these are feelings that I can have. And that I can trust people. But when you grow up in that, that really just becomes solidified and becomes that negative core belief that we are not worthy, we're not worth it. Like, if you keep throwing that on, and then you bring in the societal pressure of, are you somebody who is not white? Are you somebody who is not male? Are you someone who is not straight? Are you someone who is not rich? Like, we can keep going on with these different factors and intersectionalities that we see ourselves in. And I think when you have a provider who's able to see the client or the individual's intersecting identities, then you have a provider who understands. So, like, I very much understand that I am a white gay man who grew up in the South who's working with people of color communities. And in the process of doing that, I also understand the importance of like the sacred invitation, for example. So, like, I'm not just going to casually show up somewhere and expect for things to happen because that's just not how this works. I showed up in your backyard. Why am I expecting things from you if I show up in your backyard? It should be vice versa. And there was a community member who I've worked with for years now who really brought in the fact of like, if you continue to show up, people will recognize your face and then you become trusted. Don't just show up thinking you're going to be trusted right off the get-go, because that's the quickest way to get kicked out of someplace.
Absolutely.
So yeah.
Absolutely. Just both of you just lead with so much humility and just willingness to learn. And I just think that's so powerful and incredible. And I do see that we have a question in the chat. And so I want to get to that. But Dylan, I wanted to just kind of, you touched on this a lot. And so you talked a lot about trust. And so, in that trauma informed space, we asked Dr. Martorella how she kind of fosters that trust. And so what do you think is something that medical providers can learn from mental health practices that really engage that rapport? I know you said showing up consistently, but are there any other kind of, takeaways you want to highlight on that note?
My favorite thing, honestly, so like I used to work in the hospital for like years and years and years prior to getting involved in HIV prevention. So like medical is nothing new to me, but I love it when like clients show up and they're like, so here's this sheet of paper that my doctor gave to me and I have no idea what it says. I'm like, okay, let's kind of start there. Like, so being able as a provider to bring it down to those colloquial terms, like, let's be very honest. Like, I mean, if we're talking about like the Black community, for example, you got the sugars, you got the pressures, you got the things, like, because that's just the colloquial terms that we have in these certain communities for high blood pressure, diabetes, so on and so forth. So having that humility, if you will, to know like who are the folks that you're working with and to provide a space for the client or the patient to ask these clarifying questions. Because like something big that we really don't talk about a lot is like that concept of like white wall syndrome. And so like when you first walk into a doctor's office, like we can be prepared as much as we want to be. I have the questions, I have the mentality. I walked in with my coffee and then I saw those white walls and I was like, what am I doing here? I don't know where I'm at. So like also having that extra level of confidence from a client perspective, really, to come in with these questions. And then I know that kind of like Dr. Matarel brought up this as well, like providers only have X amount of time with a client versus a case manager, a mental health provider, the tech even, and the tech might have real intersecting identities that the provider
Absolutely.
might not. And kind of realizing that like everyone does kind of play a part here, and eventually all of it needs to become kind of enmeshed so we
Yeah.
can have a full 360 approach.
That's awesome. It's kind of like a soccer team or any sports team. You need folks with different specialties all coming together to get that same goal. And I have a lot of my background as a community health worker, and so just hearing both of you talk is, I'm trying not to get too emotional, but our folks are dealing with so many different heavy barriers and pressures and all of that, and so just to feel listened to feel valued, to feel seen. I'm just so grateful that, you know, folks are connected with you all. That's really incredible. And so looking at our Q&A, we have a participant question. And I believe, Dr. this might be for you, but Dylan, please feel free to go ahead and, you know, add to this, because I think that you both probably see a lot of this in your field and in your work. So this person managed, and thank you so much for your question. This person manages the Hopwa STRMU Housing Stabilization Program. Because housing instability often disrupts care, engagement, and medication adherence, like we talked about, what process does your clinic, doctora, and you know, what process do you and your space, Dylan, use to assess patients for housing instability that may qualify them for short-term assistance? So how do we deal with housing?
Yes, so that has been coming up uh, way more often in the past few months than in the last 15 years. And the issue in Massachusetts is that there is a waiting list, and that waiting list has gotten bigger, larger in terms of waiting times. And then there has been some changes in immigration that has also contributed to that, the who is gets preferred in terms of needs to get housing. So we have people bring it up, and when they bring it up, it's easy because they are bringing it up. But sometimes one of the things that we do, there is a different types of research. There is clinical research, medication. There is also surveys, and we do those a lot. We do like 3 of them per year.
Oh, wow.
And some of them are targeted to different populations. So we have one now that is for the elderly. What are the needs, right? So we have had one that is for general population, not elderly. And it looks more into those social aspects like housing or transportation, stigma, race, different ones. But housing is one of those, the different needs and things that are not in the survey that they think are important to bring up in terms for the practice. The practice uses those surveys, and they are not done by me. They are done by someone that we collaborate with, that they are experts on preparing those types of surveys, but they are very helpful. Uh,
Mhm.
we don't distribute them to everyone, but we distribute it to whoever wants to participate, right? It's voluntary. And we get a lot of information. And lately, housing, besides people bringing it up, it has come up in the latest survey. We have there is a medical assistant in the practice that is, different medical assistants have different uh, jobs or different tasks where they are better or they prefer. So we have someone, the same way that we have one that is the one that does the prior approvals for medications. We have one of them that used to work in a CBO and
Yeah.
she brings a lot of that knowledge. So she's very good at identifying, who to then contact. We already have contacts, but with the changes in funding, that has
Yeah.
also, they have lost, community-based organizations have lost a lot of their workforce.
Mm.
And people that we were in contact with, they are not there anymore, right? So we have
Wow.
had to constantly update
Yeah.
or try to update our databases, but she's very good with that. So right now, I would say that the way that we have tried to do it is establish like a key person to do
Okay.
specific tasks, and that has been helpful. The same with mental health providers, right? There is a shortage, and insurance. Lately, insurances are covering less of certain services, dental. So for housing and many other things, that's the way that we try to identify some of them and then address them. And again, maybe there is something that we have not identified or we identify through one of those surveys, and then we assign someone to, depending on their knowledge and interest, to then deal with that particular task Open communication, what I said earlier, important to be in open communication with the different community-based organizations, case managers, medical assistants. They are from the community in my practice, so they know a lot. They patients tell them that some things that they don't tell me, right? The same way they
Sure.
do with case managers. And then, I have to go back in because the medical assistant told me something when I got out of the room. And I'm like, well, they didn't tell me that. Let me go back and see how without, I get afraid that they will then not trust the medical assistant because they are telling me. But when it's really important or things like that, I do go back in and then those things get addressed. And if they cannot be addressed at that particular time, we make sure that we have the phones, the emails, everything, so that the referral process can be done and then they can get reached. Because the fact that a referral gets done doesn't mean that it happens.
Right.
So even that we have had to learn to follow up on, right?
Hmm.
And it takes more time and more staff,
Yep.
but if not, then they come back in 3 months and nothing happened. If we have
Hmm.
someone on top of it, then there is a higher likelihood, especially because, they may have phones that are by minutes. So then when they get the
Right.
phone call then they don't answer and they are nowhere to be found, or they don't recognize the number, or they think it's someone else, right? So those things are barriers that then I have learned that we have to also help with that, the trust, at least they trust us, hopefully, or most of them or many of them, to then we call or we send an email, okay, let's try this again, or let's see what's the barrier now to try to address it and make sure that you get those services. um, Housing is one of those examples.
No, that's great. Housing is such a um, underestimated and incredibly impactful social determinant of health. That, in my time, like I said, as a community health worker, it was often really difficult to see the additional challenges. You're already dealing with housing instability, and then there's just so many other complicating factors on top of that for the client, for the patient. And you just want to help them and advocate for them, and so they're very lucky, to have that support. And I love that you mentioned the aging population. Folks aging with HIV need support. We have this amazing cohort of more and more folks aging with HIV, which is a blessing and an incredible thing. But we need to make sure that we're supporting them as well. And so, Dylan, do you want to kind of speak on the housing and what your program is able to offer, or how you all respond to that kind of because it's a crisis.
And yeah, no, it totally, this is a public health crisis. Let's go ahead and call it what it is, even
Absolutely.
though a lot of people don't want to recognize it, because housing is one of those things that, like, I know I keep coming back to Maslow, but it is a thing where
Hmm.
if we don't have housing, what does the rest of my life even look like?
Hmm.
So the one thing I want to bring up is, and Dr. Martha brought this up earlier as well, like I want to meet you so bad. Like
Yeah, can we all
um
get coffee or tea sometime? That
yes,
would be
but
really great.
let me know when you're in Florida.
Yeah, or DC.
But no, like the big thing that I really love to drive home, especially like when it comes like looking at like what area of the world we're living in, no one organization is utopian. No one
Mhm.
organization can handle literally every single aspect of a human and their needs from birth to death. So understanding that there are a bunch of different organizations who do their own thing in different sectors of human services. So, making effective collaborations with organizations that align with your values. So, I'll say that again. Make
Yeah.
effective collaborations with organizations that align with your values. So, like when we look at the housing feature, for example, I nothing against faith-based organizations. There are a lot of amazing faith-based organizations, and then we have some organizations, faith-based or not, that are anti-LGBTQ, that are xenophobic, that are this, that, the third, whatever. And so really kind of understanding who are the organizations that you work with. And then the same also goes for accessing funds from these organizations. Like, are we accepting money because it's money, or are we accepting money because it comes from a reputable source? Is this blood money? Not to make it seem like it was weird or anything, but it's the reality of the situation. So yeah, making those effective collaborations with people who align with your values.
Yeah. No, absolutely. Thank you for highlighting that. And I know Dr. Martorell also really, brought up that partnership aspect. And, we don't have to recreate the wheel. We can reach out to our partners who have been in this space, who have done this work, who have built these programs. And they're truly our interdisciplinary colleagues. We can all work together to get the same effect. No one's taking work away from each other, in that matter. And, just again, a little bit of my background is I one of my populations that I worked very closely with, and I think I learned the most from was people who use drugs, people in active, substance use, and like Dylan, like you said, looking for organizations who are not going to take services away from people. That's a really big thing. Is some services are not willing to work with people in active use. Maybe they're looking only in that recovery space, and so that's kind of something that comes to mind when I think of looking at folks that align with your harm reduction approach or, whatever that looks like from your perspective. I saw you unmute. Did you want to jump in? Please, please.
Yes, absolutely. So we have a syringe exchange that we do a lot of amazing work with. It's so here in Florida, we had the Idea Exchange, which was based out of the University of Miami. And then Rebel Recovery came along as the second legal needle exchange here in the state of Florida, based here in Palm Beach County. And I actually went to grad school with their executive director. Love her to pieces. But understanding, like, utilizing organizations like a syringe exchange, like it, not to make
Mhm.
it sound weird, but it's a built-in population that needs
Sure.
help. So like
Yep.
as we keep talking about substance use disorder also changes throughout time. So like before we had all these opioid laws, there were a ton of pill mills. But we're not giving the suburban mom who takes Xanax the same attention that we're giving the migrant farm worker who uses heroin, but knowing that they both carry the same form of risk, if you will, from using opiates and having whatever type of situation that they're putting themselves into. So, yes, find a syringe exchange, start one, talk to somebody. If you want to talk, please reach out to me. Syringe exchange and harm reduction are my thing.
And I think that's so important to always, you both touched on it, but just understanding that, your healthcare provider is not there to judge you. They're just to understand your full story. They're there to see the full picture of, where you situate yourself in. And so, and if your provider is not making you feel that way, if they're making you feel judged or you don't feel comfortable, then maybe it's time to look for a new provider or to reach out to one of these amazing, specialists we have today on this call to see who they might recommend, because I'm sure that their networks span across the country. But opening back up, Doctor, I don't know if you want to start with this question, and I'm just thoroughly enjoying this entire conversation. So thank you all for this amazing input, and I love where that question got us, started on. So how do you both address misinformation or stigma when it comes to HIV prevention and treatment and the communities that you serve? And, we just kind of talked a little bit about telling your provider the whole story. And so, how do we foster that feeling of safety, but also dealing with societal stigma that we're not in control of as providers and goes way outside that point of care. There's a lot of things that we're not in control of. So how do we handle that space of stigma and misinformation in 2026?
Um, that's, complicated too. But I think
A
part
little
of
bit.
what Dylan mentioned earlier, judgment, that's one of the things that I see a lot of clients that go to different settings and even mental health, and they feel that they are being judged. If they feel that they are being judged or rejected or not being taken care of the way that they feel they need to, it's going to be very difficult to establish the trust. And, this HIV is one of a few conditions where there is a high stigma still attached to HIV. And a lot of it is because of what I just said, but also the misinformation in the community, right? Even family members there is still a lot of people that believe that HIV can only be acquired by certain groups of people. And the awareness, the issue of education is one of the things that I have always, ever since I opened the practice, education and prevention has been very important for me. I have evolved in that era of I am older than you, than both of you, and I didn't grow up with the social media. I have had to learn that, and slowly, in terms of information, there is so much of it and misinformation that what I try to do, not only uh, go and do educational sessions in, I was just reading the chat that Jocelyn sent earlier about New North Citizens Council, and you see how even activities like this open your mind. Now I also know, or I had forgotten about their housing program, right? They work 5 minutes away from where I am. And we collaborate a lot. New North Citizen Council is one of those CDOs that my practice collaborates a lot. We have gone there and done a basic education for clients and the staff as well. And there are some other CDOs like Gandara in the region, even Tapestry, many others that we have collaborated. But the latest thing, besides doing educational sessions on HIV prevention, STI prevention, hepatitis C, right, that can be cured, and a lot of people don't know that, and with the newer treatments, I have incorporated social media. My daughter taught me about TikTok. I had
That's
to learn
awesome.
with my daughter about
That's
TikTok.
awesome.
I was like, and not only TikTok, even Instagram or, the other social media. And what I did is I started preparing very short videos on different infectious disease, primarily infectious disease topics, even though they are not all infectious disease. And then I started getting patients asking me, can you do this topic? And can you do this topic?
Sure.
And even though I have not been able to keep up because I wanted to do one every month, it's been ongoing, and you see more people listening to them or making comments. And I think that is something out of my comfort zone, but that I have had to learn and adjust and do. And it has been helpful because of course, I always may also get negative feedback. That one was boring, or you
Yeah.
should have added this, right? But overall, the feedback is positive. So that has also helped, with the same organization that we work on the surveys. They also provide educational slides for providers and clients,
That's
and
great.
some of them on site, some of them out of site, like virtual. They can be virtual like this, or
Mhm.
on site, where they provide food for clients who come in, and we do very basic informational sessions. And, when someone tells me something that I know is not accurate, I try not to attack that. I listen,
Yeah.
and then I try to provide information because, social media, the same way it can be positive. If you read something, the feed, right, that you keep
Yeah.
getting information that maybe is not always what you need to read or accurate. So I just try to go with the flow and then provide, additional information. And even people who initially said no to things, they don't want to get a
Yeah.
vaccine, for example.
Yeah.
Many, I don't want to say everyone, because it's the same as changing an HIV regimen. Not everyone will be willing, even though you recommend it and you explain. But change happens. It takes time.
Mhm.
Trust, being not judgmental or trying not to, having them understand that you as a provider, you're not perfect, right?
Yeah.
Because it's true. I am not, and I try to realize that if you make a mistake, you admit it, or you
Mhm.
say, we can do this instead, or I should
Sure.
not have said that, right? And that is helpful a lot in addressing not only information misinformation, but that trust, non-judgmental aspect of what we were talking about.
That's great. Dylan, you're welcome to continue and add a little bit onto that, but we also see another question in the chat. So I see that Natalie has sent in. Can you talk about non-HIV providers understanding of U equals U or I equals I, which is undetectable equals untransmissible, and the role it has in supporting woo woo, the role it has in supporting HIV care? If you wouldn't mind touching on that, since you've been in the HIV space for quite some time.
Over half my life. I love it. No, I,
Congratulations.
I would like to think I'm that young. But no, so like going back to the previous question for like two
Yeah,
seconds.
for
So
sure.
I was previously an ambassador with the CDC's Let's Stop HIV Together initiative, and one of the things that I really loved utilizing when we were funded for HIV prevention here at Compass was the SNS, so social networking strategies, evidence-based intervention, which was very synonymous with what Dr. Martorell was bringing up earlier with this is what was around prior to social media. So if you look at SNS, it actually started with working with networks of drug users in New York, and it looked at how we can disseminate medical information that is both accurate and real to people within networks that we're not able to always access. So one of the big things that they utilize is popular opinion leaders. So those are your church leaders. Those are the owners of the bodega. Those are the people who set up Dia de los Muertos. Like these are the big people who know people in the community.
Sure.
So utilizing them to disseminate information. I've used drag queens all the time. Like when I'm
Yes.
trying to get in touch with the baby gays, I'm like, I don't go out that often anymore, but hey, you're hosting a show on Friday. Can you just like say like if you want condoms or prep or testing to like call Compass?
Yeah.
It's as simple as that. You just
Yep.
ask and like they're part of the community as well and also probably utilize these same services. So if anything, they're preaching to the people
Mhm.
who we're working with. Um,
Absolutely.
so I'm not gonna lie, can you repeat that question again?
So I just, and you probably you encourage folks to do this every day. So how can non-HIV providers, what is kind of their current understanding of U equals U,
Okay.
and how can we work with that?
Yeah, absolutely. So U equals U, undetectable equals untransmittable. I know that this is backwards over there, but that's what it says, I
Nope, looks
swear.
great.
So Bruce Richmond actually created this initiative back a number of years ago. And then you had a couple of different groups that came after that. Basically, the concept is if you have an undetectable viral load, you have no risk of transmitting to your sexual partners. And this is where we start having different conversations depending on the community that you work within. So, like, what is the science showing? Does this community necessarily believe the science? Do they have medical mistrust? Is there medical trauma in the background? So, kind of also bringing it down to like someone else's level. So, yeah, basically, like, I don't know. I love a chart. I love to just show things, being like, oh, so like if you weren't taking meds, your viral load would be way up there. You're taking meds, it's way down there. And when it's way
Yeah,
down there, you can't give it to anybody else.
But
Basically,
also the importance of that conversation is that it may also lead to PrEP, to
yeah.
HIV prevention
yes,
treatments. A lot of people do not even know, right? So the concept of U equals U may open up a
yeah,
big big conversations in terms of not only treatment, but prevention. The availability of oral tablets for PrEP, injectables for PrEP that people don't know. There is one that is every other month. There is one that is every 6 months. And
yeah,
people do not want to do tablets, but they may be willing to do injections for the privacy, things like
sure,
that. It also opens the conversation for doxypep, prevention of sexually transmitted infections like syphilis, gonorrhea, chlamydia,
yeah,
things that people may not even be aware of or not even think about or not even know about. So every topic and every setting, even at my clinical setting, of course, I go over that, but that's part of the education. And that's why I like to do a lot of education because
absolutely,
even for providers, even for infectious disease providers, some of them don't know these things,
yeah,
right? And I think that that's the beauty of, the changes and updates and improvements in care. But one of the things that I always say, and we have all agreed on that, is uh, providers have to care. They have to like what they do. And in the HIV space, usually most of them do, which in my opinion tends to be different than in other areas of medicine.
Definitely.
But it's the only way, because the only way that people will do well is if they can trust and if they can have that access to those services. And it may take for some people quickly one day, but some other people it may take years, right, for that to happen and be achieved. And the importance of collaboration, because I may not necessarily be able to, I don't want to say convince, but be able to be successful at prescribing doxypep for someone, but then they see Dylan, and then Dylan is able to transmit that information in a different way or the same way,
Yep.
but the person heard it
Yep.
differently or said, okay, wait,
Yep.
So I have done that a lot. Collaborations,
Right.
Yep.
collaborations, they lead to success in
Yep.
terms of not only the access, the trust, but also quality, quantity, and quality of life, which is so
Yep.
important.
And I think U equals U, and in my perspective, does a great job of starting with the education piece, like you both, touched on very much, and just destigmatizing. You can live a healthy, long, life with HIV, which is an amazing, kind of feat of advancement in scientific discovery. And I think we need to talk about, across the board how we see the whole patient, and there are people who are untransmissible and living with HIV, and we have tools, we have prep, we have doxy prep, we have all of these things. So no, I think that's just so important to mention. I looks like we just have a couple more questions, and we have one last a couple more minutes, and we have one last question in the chat. Try that again. So we have a question from a STEM instructor and a software engineer. So really flipping the table here. Um, are there any tech tools that you feel could help you all out more, or that there's a need for in the HIV space? Curious if tech could assist in any way with accessibility, like language barrier, medicine and mental health services. We've reached folks through a lot of different modalities. Not everyone has the access to the same types of technology. So if y'all would be willing to discuss that in our last couple of minutes together.
Well, what I can say, again, I'm not an expert on technology, so I'm not sure how to answer that, but
Well, you're using it.
Eh,
So
I
good
am
job.
using it. Yeah,
Yeah.
no, but I think there is a need. Which one specifically and how to do that, the engineering part of it or software engineering, I'm not sure, but there is a need, language barriers, cultural barriers, mental health, substance use, I mean, topics, and the need is ongoing because things change, even prep, when I did the initial video on social media, the injectables were not one of the injectables was not approved, right? I see that Dora wrote that PrEP has
Yeah.
been approved since 2012, and still primary cares don't know about it. It's true. Even
Absolutely.
infection doctors don't know about it, and they should, right? So that aspect of education is very important. You know what I tried to do with my TikTok was to do 5 minutes in Spanish and 5 minutes in English, because I'm
Oh,
bilingual
nice.
and I could do it, and I chose to do it that way to then make sure that a lot of my monolingual Spanish patients could also have the
Mhm.
access. But I think now with artificial intelligence,
Yeah.
which I'm not an expert on that either, but slowly I'm
Right.
trying to, it will be helpful. So I don't know, Dylan, if you have any
Yeah.
comment about for Cam Holdren, but that's what I can say.
Thank you.
Yeah, absolutely. And I love this conversation because there definitely is the need, the want, and the ability for technology to be incorporated into sexual health, mental health, so on and so forth. So like I remember, for example, when we started offering different prevention options on apps like Scruff, Grinder, Sniffy, so on and so forth. And you saw them like slowly start adding them in little by little. So like we had condom only, bareback only, and then like we start talking about like, oh, I'm on PrEP. Here's DoxyPep. I'm undetectable. And then I've seen people explain in their profiles, like, this is what it means to be undetectable. If you don't even
Yeah,
understand like any of this, don't even worry about messaging me because I'm not here
absolutely.
to educate. Like, I'm here to have sex. If you
Yeah.
want to learn more, go to these websites and stuff like that. So, speaking of the online communities, I really love the organization BHOC. So, Building Healthier Online Communities. They work with all of the major app providers to be sure that they are up to date on all things sexual health related, consent, so on and so forth. Gilead put out Healthy Sexuals, which is also a very comprehensive website and information that, like, let's be real, we're all trying to pick up the pieces of where the public school system left off. And
Sure.
probably me being a millennial and even before then, depending on where you're at in the country. So we're always trying to catch up and explain to people things that they should have learned earlier on. So if there is easy to digest information, is it a chart that I can easily read? Stuff like that. And then finally, I was on a webinar a few years ago with the Latino Commission on AIDS, and there was an individual
Yes.
on there who created the app, The Bigger Blacker Book, in which I absolutely love it. I love it when my clients come in showing me, being like, oh, well, here's this. Because, like, at first, I feel like we've all had that notes app or an Excel spreadsheet with our sexual partners. The amount of people in my phone who was like, name, bar, name, shirt, barely a name, barely an adjective, whatever. You put that all in here. And the Bigger Blacker Book tracks your sexual encounters. What type of
Wow.
sex was it? Were you sober? Were you under the influence? Did you use condoms? So on and so. When was
Yes.
it? When do I need to get tested? When was my
Wow.
last test? Like, when I tell you it's the little black book that we've all talked about that goes with the little black
Yes.
dress. This is on steroids and for your average homosexual. It is
Yeah,
great. Well, beyond homosexual, but we
absolutely.
kind of understand.
Yes.
Like,
Yes.
this is the
Yes.
field we work
Sex
within. But yeah,
positive is so important. Let's be honest about what we're doing and how we're doing it.
honest, like, and that's where we also kind of help ourselves not
Yes,
shoot ourselves in the foot when we're having
absolutely.
conversations with our providers. Like,
Sure.
the my provider, love her to pieces, gone to her for the last 8 to 10 years, but we also serve on the Palm Beach County Prevention Board together. So I'm totally fine having conversations with her. And then, like, you have like the little, I don't know, barely 18-year-old who's coming in here being like, I don't know anything because they didn't
Yeah,
teach me anything. And we're
right.
truly starting from ground one, but instilling prevention from day one.
I love that. I love that. No, I think there's such a place for technology, and whether it's communication, dissemination of materials and all that. And while we're still learning about AI, we always want to protect privacy and safety of our patients. But there might be a place for that. And so, unfortunately, we have run out of time. I feel like I need to have y'all in person so we can do this for an all day. Um, this is just so incredibly invigorating and inspiring. So, thank you so much to our speakers, Dr. Martorell and Dylan Brooks. You all are incredible. Thank you for your time, your insights, and your overall commitment to people and to HIV care. It's just such an important conversation. So before we close today, I just want to highlight some of the important resources that NHMA offers. Dylan actually touched a little bit on some of the CDC's Let's Stop HIV Together campaign. So we encourage you to explore these materials and share them. They're free, downloadable, easy to access. And so, whether it's public health education or advocacy, absolutely feel free to use this as a toolkit. We have a very exciting event coming up. We would love for everyone who's able or interested to join the National Hispanic Medical Association May 27th to the 29th in the Washington, D.C. area. Maybe message me to get some coffee. I'd love to see so many of our amazing HIV friends. And it's the annual conference. So, Medicina con Propósito, empowering with education, advocacy, and leadership to connect these amazing professionals who are, working to end this HIV epidemic and to just work all across the board on different health aspects of equity and driving meaningful change. We encourage you, if you're not already following us on social media. So like Doctora said, we're all on the socials. So Instagram, LinkedIn, Facebook, Threads, stay updated, stay engaged with us. And always remember that this association is here to serve as a resource to you all and to the communities that you serve. And you can download great resources at hispanichealth.info. It's a bilingual health education hub, so definitely check that out, because Salud Hispana and Hispanic health are so incredibly crucial to this conversation, to this fight. And if you're not already a member of this impactful organization, we invite you to join the National Hispanic Medical Association Network. Whether you're a provider, advocate, student, or community leader, there's a place for you here, and we'd love to learn more about you. And last of the just resources that we'll highlight today, because there's many resources, we want to give a shout out to the job board. So before we close, NHMA offers a great job board. So for folks seeking careers, for folks looking for talent, this platform connects job seekers with over 400 active employers and features more than 13,000 job postings, especially in today's environment. That's an amazing resource. For employers, it provides over 19,000 searchable resumes with 3 million total profile views. So you can find folks to join your team. You can look for your next opportunity. And so feel free to scan this QR code on your screen or visit our website, absolutely available there as well. We are so thankful that you gathered today to take this time and to chat with us. We know everyone is doing important life-saving work. And so thank you for being part of this conversation. Thank you for being invested in the health of others. And together, we are stronger against HIV. So please, cuídese bien. Take care of yourself, and always, advocate in whatever space you're able to. So thank you everyone for an amazing hour, and we really appreciate you all.